As I said before, at the beginning of the symposium, this year we decided to increase the number of abstracts for the presidential symposium with some challenges for the presenters and the discussant. That is the way in which we see the society as a multidisciplinary society, not only focusing on drugs, but also on other aspects of thoracic malignancies. So for this press conference, we will allow each of the presenters to highlight the study that they presented. Hopefully they will be short. In 4 to 5 minutes, they will summarize the study. We will keep questions at the end of the 7 presentation at the end of this press conference. So the first presenter is Dr. Steve Lem, lung cancer screen selection by USP STS versus PLCO M2012 criteria, interim ILST findings. Steve, do you want to come here? You have the same presentation before.
So good morning. We know that screening with low-dose CT saves lives by reducing lung cancer mortality by 20 to over 20%. So, but lung cancer screening is quite different than other cancer screening. We do not screen everyone in a specific age group. So the key issue in lung cancer screening is to how do we identify people with sufficient risk that would benefit most from low-dose CT screening. So there are 2 major ways of selecting people at high risk for lung cancer screening. One is use the U.S. Preventive Services Task Force criteria based on age and smoking history. The other one is to use a risk prediction model that has been shown in retrospective analysis in several countries to have superior performance. But we do need to have a prospective comparative study to show which way is the optimal way to find people that will benefit from screening. So we conducted a multi-center, multi-country prospective study comparing the U.S. task force, the criteria using age and PEG years versus a risk prediction model called the PLCO 2012 screen prediction model for enrollment. So we have almost 5,000 average smokers recruited in 9 centers in Canada, Australia, UK, and Hong Kong who met either screening criteria. So what we found is screening the same number of participants, the risk prediction model, the PLCO model, has significantly higher sensitivity of 80% higher and positive predictive value than age and PEG years alone. And more importantly, the 18% of people who would be missed by age and PEG years criteria alone, they all have early stage, potentially curable lung cancer. So 80% have potentially curable stage 1 or 2 cancer. Only 0.3% of people that are missed by the prediction model but found by age and PEG years criteria of lung cancer, we don't think they're likely to be beneficial for a screening program. And another thing we found is we identify the optimal threshold for screening using the PLCO risk prediction model. 1.7% 6-year lung cancer risk appear to be the optimal threshold for screening. Thank you very much.
So the second presentation is from Dr. Sullivan, and it's related to early detection of cancer of the lung, Scotland trial results.
Thank you, Chair. Have most people already heard the presentation in the main auditorium? Yeah, so this is just the abbreviated version, and like Dr. Lam, it's about targeting screening more effectively. We did a phase 4 trial, really. The technology underpinning the science has been worked on for the past 20 years, going through just all the preclinical work, validation, using the case control retrospective. So this is following patients forward before it gets ready for prime time in cancer control. So the people we were targeting were asymptomatic. We tried to target the most deprived quintiles in Scotland. So we went to the practices that served the most deprived areas and searched through the records to find patients who had more than 20 pack years or a first-degree family history. And they had to be fit enough for surgery. When we spoke to the thoracic surgeons about this study, they said, don't send us people that we can't treat. So they had to have an ECOG score 0 to 2. The test is here. You can see in the arrow 7 antibodies against these antigens. And this is really why it's an early cancer diagnosis, because these antibodies come to these abnormal proteins right at the beginning. If people had a positive blood test, they had an immediate chest X-ray and CT scan, then followed up 6 months for 24 months. If they were test negative or they were in the control group, then we just waited for them to appear with symptoms, and they just got standard NHS care in Scotland, which is free at the point of contact for everybody. And the principal outcome I'll be presenting shortly is this. It was the difference between the number of patients with stage 3-4 unclassified at diagnosis. This is a modified consort diagram. We wrote to 77,000 people, some others self-referred because they heard the study was going on, and after having a phone call to pre-screen, they were given an appointment to come up to go through all the criteria. We randomized 12,000 and the randomization worked. And that's what we found really, that there were many fewer cancers, late cancers in the group who had the intervention compared to the control group. The sensitivity and specificity are here, high specificity, moderate sensitivity, better at 1 year. Professor de Koning asked the question, how many patients tested positive? Well, out of the 6,000, it was 598. So about 10% of people have a positive test and then get followed up. And that is the main outcome that we'll be putting into the main paper that we'll be submitting next week. We were adequately powered to detect a significant reduction in late-stage cancers, and it started to become evident at around a year. We weren't adequately powered for mortality, but both all-cause and lung cancer mortality are starting to separate by 2 years, and we hope by following the patients up at 3-5 years, we'll be able to come back to the conference and report on that. And that is the conclusion slide. 36% reduction in late-stage presentation, 2 years, which seems worthwhile clinically and statistically. We did manage, because it was a relatively straightforward blood test, to get most of the patients in the deprived area, very high follow-up using administrative data, and we're wanting to move on to the screening case finding. We will have some economic data early next year, but I imagine that the full value of the test and where it sits with screening will depend on these larger studies being completed. Thank you.
Thank you, Dr. Sullivan. The next presenter is Dr. Pastorino from Milano, Italy, about another low-dose CT scan screening study in combination with blood microRNA.
Good morning. We know from how can I advance this? Okay. We know that CT screening can reduce mortality. The question is how to use at best CT in a high-risk individual. The BioMILD was designed to evaluate the utility of a combined microRNA test on the blood and low-dose computed tomography to predict the individual lung cancer risk. So for a group of individuals with the same age, the same exposure, define those that are going to develop lung cancer. Assess the feasibility of a longer screening interval, so having defined the level of risk, decide different intervals. And of course, reveal if there is a potential damage in postponing the CT after 2-3 years in terms of stage 1 resection rates and interval cancer. We registered almost 10,000 volunteers. The inclusion criteria were 50, 75, 30-pack years, and stopping smoking from less than 10 years, so the usual. There were almost 5,000 eligible, and in the end we enrolled 4,119 at baseline. In addition to Myrna and low-dose CT, they had spirometry and carbon monoxide. In essence, they were divided in 3 groups. A group of individuals with a double negative CT and Myrna. The negative CT was set up at 112 cubic millimeter, which is a pretty high level. I mean, usually the threshold, the cutoff threshold is much lower, but in fact, this was adopted in 2013. The new Lung-RADS cutoffs just recently published use exactly the same cutoff, so 113 and 2060. The group of a single positive were individuals having either a lesion above or equal to 113, so indeterminate or positive CT, or intermediate or N or I Myrna. Our test performs 3 different levels of risk, so low, intermediate, and high. The double positive were individuals having both a positive or suspicious CT and a positive Myrna. Now, 58% of the individuals fell in the double negative group, 37, approximately 1/3, fell in the single positive group, and only 5% in the double positive group. The average number of CT was 2.0, 3.2, and 3.5 in the 3 groups. Sorry, I went down. I'm going backward. Here is the lung cancer incidence curves at 4 years. As you see, the risk of lung cancer is enormously different among this group that have the same composition of age, sex, and tobacco consumption. And the risk being almost 6 times higher in single positive and 37 times higher for the double positive. The difference is significant among each of the 3 groups. The mortality rates follow exactly the same feature, although they are, of course, much smaller, but the hazard ratio is 4.6 and 32 for the double positive. Of interest, incidence and mortality in the double negative at 4 years is very low, almost flat. So the take-home message is that blood microRNA and LC together can improve the screening, reducing the unnecessary LDCT repeats. But what is more important for us, the knowledge of an individual biologic risk can improve the efficacy of screening, but can guide prevention strategies. Because the problem in a heavy smoker is not just detect lung cancer, it's reduce mortality. And so personalized prevention is a real option now, and that means diagnosis, but also preventive measure, smoking cessation, chemo prevention, and so the individual risk can trigger prevention in the future. Thank you.
Thank you, Ugo. The next presenter is Dr. Eric Lim. that reported about the Violet study, that is a multi-center randomized clinical study of VATS versus open lobectomy for lung cancer.
Great, thank you very much. I'd probably give you a lay summary of what I've been presenting today in the earlier conference. At the moment, if you have early stage lung cancer, many of your doctors will refer you to see a surgeon, because we think that surgery would be able to remove all the disease, and that would be considered the best treatment if it is very small. Now, the operation can be done two ways. It can be done through little incisions and telescopes and instruments or projected on a TV screen, or it can be done via a big cut in the chest with the ribs spread open with the hands in to get your cancer out. We think that keyhole surgery may be less painful and have a better recovery because we don't actually put pressure on the nerves when we're opening the chest. When we do the operation open, we have to use a metal rib spreader, and that can sometimes injure the nerves. But if we are going to do a keyhole operation, how is it that if a surgeon cannot use his eyes and cannot actually feel the cancer, would he be able to get as good a cancer removal compared to just using instruments on a TV screen? So for the clinical trial, we had to define what was keyhole surgery, and we ensured that the surgeons can't use their naked eye to see inside the chest, and there was no rib spreading. And principally for open surgery, the surgeon could see inside the chest, get his hands in the chest, and also spread the ribs to get access. We made sure that the lymph node harvesting and pain management was standardized, and after the operation, we had a big dressing over the wound, so you couldn't tell if you had a keyhole operation or if you had an open operation. In fact, we actually tested the patients. We asked them, can you guess if you had a keyhole operation or an open operation? And actually, none of them could. So there's a 50% correct guess, which is no better than flipping a coin. We screened over 2,000 patients. We've randomized over 500 patients. We achieved it to time and to target. And we had very good surgical quality. We had a very low mortality rate. We had a very low benign resection rate. Keyhole surgery was performed through 3 keyholes in the majority and 1 keyhole in about 20% of patients. We had a very low conversion from keyhole to open surgery, and that's a marker of the maturity of the keyhole technique. If the conversion rate was very high, then we would have concerns that the keyhole surgeons maybe weren't that good. But in our study, our conversion rate was relatively low. We found that pain was lower in the keyhole operation group, and having adjusted for all the painkillers, it resulted in half a unit lower pain score. The need to adjust for painkillers is very important. If you have a cut and your pain score is 1 out of 10, your pain score could be 1 out of 10 because you're on 1 tablet of paracetamol, or you have 10 milligrams of morphine. So the paracetamol and the morphine dictates your pain score, not actually how much pain you perceive. And that's why for this sophisticated analysis, we had to adjust for each and every single pain medication patients received. The length of stay for open surgery was 5 days, and is 1 day shorter for keyhole surgery. And we did more sophisticated analysis to adjust for any other confounding variables. In terms of cancer clearance, we found that the number of lymph nodes that were harvested was the same in both groups. The number of lymph nodes harvested is very important because it can change your treatment after the operation. If you have N2 disease, patients will be recommended chemotherapy. If you have N1 disease, all these are important. And people say that, well, actually, taking the number of lymph nodes out, whether you do an open or keyhole, is not really a big a deal. It's not very discriminatory. If you are a good surgeon and you take a long stretch of lymph nodes out, there's a much higher chance you will pick up disease which was not otherwise detected before the operation. And we found that keyhole surgery, to our surprise, actually picked up even more lymph node disease than actual open surgery. And this is one of the first randomized trials to show this, because all previous studies, mainly that were not randomized, showed a very big difference in lymph node upstaging. It was much better with open. But when we used the surgeon as his or her own internal control, we found that access didn't actually make any difference. What we found was a startling 26% reduction in hospital complications if you had keyhole surgery with no increase in any serious adverse events. And whilst bleeding occurred in the keyhole surgery arm during the operation, it also occurred in the open surgery arm. The benefits for keyhole surgery were mainly reducing kidney complications and infection complications. So we concluded that keyhole surgery is less painful, has less complications, leading to a shorter length of stay in hospital for our patients. And this was achieved without any compromise to cancer clearance of the cancer operation and without any compromise to any serious adverse events compared to open surgery for lung cancer. Thank you very much.
Thank you. The next is the Libretto 001 study, that is a phase 1/2 trial of LOXO-292, that is a new agent for red fusion positive lung cancer. The presenter is Dr. Drillo from New York.
Thank you. So I'm going to give you guys the cliff notes since you've already heard the formal talk. So important for you to know that RET fusions are bona fide drivers of lung cancer. These share many features with ALK fusions or ROS1 fusions. And actually, this is an underserved population of patients. And as you can see in the second major bullet here, we've really tried hard over the last couple of years to develop older, dirtier drugs for these patients. These are the multi-kinase inhibitors. But those clinical trials have been fraught with issues related to low response rates and really substantial toxicity. So the difference between selpercatinib and those drugs is that selpercatinib is a selective RET inhibitor. So it's a cleaner drug, as you can see from the kinome diagram on the far left. And it avoids or does not meaningfully hit these other targets that result in side effects in other patients. As you can see, the middle, it's very active against many models, and you'll note the additional feature of the drug that was designed to be active against resistance mutations like the V804L gatekeeper mutations. And then another important feature that we like to see for our patients is obviously very meaningful activity in the CNS, which you see on the far left. Now, these are the top-line results, and I'll remind you this was the primary analysis set. This was designed in collaboration with the US FDA. This was the first 105 patients with RET fusion-positive lung cancers detected by a local test who had also had prior platinum doublet chemotherapy plus minus immunotherapy. Notable features of the waterfall plot, you'll see the vast majority of patients had disease shrinkage. You're seeing very deep responses and complete responses to therapy. You have a very nice objective response rate of 68% here. And then as I mentioned earlier, the drug was designed to meaningfully penetrate the blood-brain barrier. And here we're seeing meaningful clinical intracranial activity with an objective response rate in the brain of 91%. So that not only means that you can use this drug for patients who already have existing disease intracranially, but also, as we've seen with other agents, you can use selpercatinib to potentially prevent the acquisition of brain metastases, which of course spares patients a lot of morbidity. This is the durability of response, both in terms of duration of response on the left, where you see a median of 20.3 months, and the median progression-free survival on the right of 18.4 months. Another key feature of this trial is that this program tried to mimic what oncologists do on a daily basis. And so if you look at the first bullet below, patients were allowed to be treated beyond progression. And so a sample case would be someone who had solitary site progression in one area or oligo progression. Clinicians were allowed to do local therapy, remove or radiate that singular area, and then thereafter continue the drug. And as you see, the longest patient with ongoing TKI use post-progression was in excess of 1 year and 4 months. Now, we also looked at patients beyond the primary analysis set of patients who were treatment naive, had never got any systemic therapy before. And as you can see here, another fantastic waterfall plot. The vast majority, again, had disease regression with therapy, complete response to treatment, an objective response rate which is higher than in the prior slide at 85%. Finally, in terms of safety, as I mentioned, this drug was designed to be very clean and very selective. And so while we don't have the adverse event profile of prior, dirtier multi-kinase drugs, trust me that what we're seeing with selective RET inhibition is very far away from what we're seeing with the older agents. And so I think the best integrated measure of that is if you focus at the very bottom of the table, you'll see that there are very few patients who discontinued drug because of treatment-related adverse events. So it was only 9 out of the 531 patients who were treated with all different types of cancers, regardless of RET alteration, who went onto the trial. And as you'll note in the table, most of these side effects were grade 1 or 2 and very easily managed. Finally, we did mention that the drug was designed to target resistance, and some of these older drugs can engender gatekeeper resistance, and this mutation, the 804L gatekeeper, is an example of that. You see here that this drug successfully overcame this in a patient with a V804L gatekeeper mutation. She felt well very quickly, so she had a rapid clinical response with decreased shortness of breath, and also had a confirmed and ongoing response, and she's approaching a year on therapy with selpercatinib. So conclusions here, we're seeing a new drug, selective agent, very active, durable disease control, favorable safety profile. And if you're looking, those really check all of the boxes of favorable features that we like to see with drugs such as osimertinib and alectinib that are approved for EGFR and ALK reliant cancers that have very selective activity against resistance, and also activity in the brain. And finally, an NDA is planned for the end of this year, as you can see on the slide. Thanks very much.
Thank you. The next is Dr. Middleton, that will report about the results of the National Lung Matrix trial.
Thanks very much indeed. So we presented the data from the National Lung Matrix trial, and I really just want to put it into some context with what we were trying to achieve in this particular program. So this is a very large study, an umbrella study where we had lots of different arms of targeted agents with specific targets that we were going for. Now what we knew, and we've known for a long time now, that there are certain groups of patients with lung cancer that have got genomic aberrations that can be very effectively targeted, the so-called oncogene addictions. We've known since 2004, for example, that EGFR mutant patients can be treated very effectively with EGFR inhibitors, and we just had a fantastic example of RET fusion patients treated with really highly active RET inhibitors. What you've got there is you've got a genomically simple tumour, often in a non-smoker with not lots and lots of other mutations, for example, and lots of genomic instability, that's got one driver that drives that tumour, that drives it to proliferate, drives it to avoid cell death. And when you switch that off with a single agent, it works fantastically. So you go, what we tried to do in this study was to ask a particular question. If we've got 20% of patients with lung cancer that have got these great responses to monotherapy, how many slices of the molecular pie are there? How many other patients might there be out there with specific drivers that we can target with targeted therapy? This is what we really wanted to ask the question. And specifically, we wanted to ask the question, are there any good targets in patients that smoke? Okay, the vast majority of these patients that respond really well to these monotherapy targeted agents are non-smokers, as I said. We wanted to know something about whether patients with tobacco-associated non-small cell lung cancer, and in particular squamous cell lung cancer, because these are all largely adenocarcinoma, we wanted to ask the question, could we find some decent targeted agents, some precision medicines, some personalised medicines for patients with squamous cell lung cancer? So basically, as I say, we had an umbrella trial of multiple single-arm signal of activity phase 2 trials. And this is the study design, so there's lots and lots of arms in this. We've actually, at the moment, got 22 different biomarker cohorts, okay? In other words, we use next-generation sequencing. We found out what we think the driver might be in that particular patient, then we match it up to one of 8 targeted therapies, as you can see down here. So quite a big study, and what we reported out on today was 19 of these arms. Now, I'm going to keep it brief, because I just want to make one specific point about all of this, okay? I've just got a couple of data slides that I specifically want to point to. Now, the first one is this one here. This is using a drug called palbociclib. Okay, it's a CDK4 inhibitor. And you've got 4 different cohorts here, and I'm not going to go through the statistics again, but 4 different cohorts which just basically show the median progression-free survivals. They're actually the Bayesian estimates of the median progression-free survival. And you can see here that the PFSs range from this one here, this is CDK4 amplification at 2 months, up to 4.5 months for this one here, which is CDKN2A loss in squamous cell carcinoma patients. Now, you've just seen the stuff with RET fusion, where you've got these huge progression-free survivals. If you look at ROS fusion treated with crizotinib, that's out at the 19-month mark. If osimertinib, that'll be out at the 16-month mark. You can clearly see that with this drug, with this particular group of patients, we're not seeing anything like that. And indeed, particularly, we're not seeing anything like it in these squamous cell patients with these CDKN2A losses, which is the commonest abnormality that you see in squamous cell lung cancer. Similarly, one of the commonest mutations you see and the commonest amplifications you see is in PIK3CA. Okay, so we thought, well, we'll take patients with PIK3CA mutations with squamous cell tumours or PIK3CA amplifications, and we'll treat them with an AKT inhibitor that's immediately downstream of that. And we thought that would probably be a good idea. But in fact, you can see here that for these patients, so these patients F1, that's PIK3CA mutation, F2 is PIK3CA amplification, look at these. Durable clinical benefit rate, that's stabilisation or better at the 6-month mark, is down below 15%, and we've got no responders at all. In other words, again, a very common mutation in squamous cell lung cancer that we rationally targeted with a targeted therapy, we're seeing very, very little. And yet this study clearly shows that we can pick up oncogene addictions, because down here, we've got a group of patients who've got standard oncogene addiction. So at the bottom here, these are T790M EGFR patients responding beautifully well to osimertinib. And then we've got 2 crizotinib cohorts, one with ROS fusion and one with MET exon 14 skipping mutations that respond really well. This is what you see with oncogene addictions: massive levels of DCB rate, very high median progression-free survivals, very high objective response rate. So what does this all mean? What does this mean for the patients that have got these smoking-related cancers, and in particular the squamous cell cancers? Well, what I think here is that this really, for me at least, is, if you like, the beginning, the sort of end of the beginning. Right? We've done lots and lots in terms of targeted therapies, particularly in non-smoking lung cancer. We've got to think again about what we do with patients, particularly with squamous cell lung cancer. I don't think we can copy the paradigm of single agents going for oncogene addictions. That's not going to work. If you look at this waterfall plot here, this is by the entire trial by histology. And out here, on the right-hand side of the waterfall plot, the patients are doing well. These are all the non-squamous patients. Squamous patients, look, they're only over this side, okay? We're seeing very, very little, if any, of significant responses. So just my final slide, really. It may be that in these patients with squamous cell lung cancer is a good target, but we're just going about the wrong way of approaching it. We think target, we think single agent, and then we expect it to be a massive response rate like RET, for example. I don't think that's the right way forward. These 2 drugs that I've just talked about, okay, capivasertib and palbociclib in these squamous cell patients with no responses. If you look in estrogen-positive breast cancer, you almost see exactly the same thing. Again, very, very low levels of activity when you use them as a single agent. But when you use them in a rational combination, it provides very significant benefits indeed. And critically, it's not dependent upon whether you've got a genomic aberration activating that particular molecule. In other words, for example, if you look at capivasertib in combination with fulvestrant and you treat those patients, it doesn't matter whether you've got a PIK3CA mutation above that or not. We need to start thinking about the targets perhaps independently of genomic aberrations activating it, and thinking about it in rational combinations. Monotherapy I don't think is going to work. And one final point is that even though we might have a good target, we've got to accept the fact that smoking-related lung cancer is very different from breast cancer. It's very, very genomically complex. It's very unstable. There's ongoing evolution, for example, lots of oncogene redundancy and lots of resistance, okay? And again, I think the very important thing is that when we start to think about taking drugs into the clinic, some of the models that we use can be very genomically simple. Okay, the preclinical models, particularly some of the mouse models, the transgenic models that really don't replicate the genomic complexity of the tumour. And we've got to start thinking about preclinical work which really does replicate the genomic chaos of the diseases that we're actually treating and the target that we're trying to target. Thanks very much.
So the last summary is from Dr. Luis Pazares that presented the Caspian study. The Caspian study is a study of durvalumab plus chemotherapy in first-line extensive small cell lung cancer.
So here are my disclosures. So small cell lung cancer represents some 15% of the types of lung cancer. It's characterized with a very aggressive disease, which is typically chemosensitive, responds pretty well to chemotherapy, but relapse typically happens quite early on the treatment. So resistance to chemotherapy happens very early. Over the last 4 decades, we have been treating our patients with extensive disease which is about 70% of the patients are presenting with extensive disease. We have been treating those patients with chemotherapy, platinum-based chemotherapy, platinum plus etoposide typically. Over the last few years, we have shown that checkpoint inhibitors, particularly PD-L1 and PD-1 inhibitors, do have activity in this setting, and particularly the combos of chemo plus those checkpoint inhibitors may be particularly attractive in the first-line setting. This trial, Caspian trial, have studied the role of durvalumab, which is a PD-L1 inhibitor, in combination or not with another checkpoint inhibitor, with a CTLA-4 inhibitor called tremelimumab, in combination with chemotherapy, in the setting of small cell lung cancer in patients with extensive disease. This is the design of the trial. Eligible patients were those with pathologically confirmed small cell lung cancer, extensive disease, no prior treatment with chemotherapy or whatever. Patients should have good performance status, good health, good organ function, measurable disease, and actually patients with asymptomatic brain metastasis or those with treated unstable brain metastasis were allowed to be included. Patients were randomized 1:1:1 through 3 treatment arms. Importantly, because we typically use 2 platinum analogs, cisplatin and carboplatin, patients were stratified by the platinum analog. Patients were given EP, platinum etoposide, up to 6 courses, because this is what we typically do in the clinical practice, and then optional PCI, prophylactic chemical radiation, was allowed for patients. One experimental arm had only 4 courses of platinum etoposide plus durvalumab, and then durvalumab maintenance treatment. The second experimental arm included EP, the same chemo backbone, plus durva plus tremelimumab, and then durvalumab as a maintenance therapy. The focus of the presentation here today at this meeting was only the comparison of the control arm, the control arm, EP, versus the durva plus EP arm. The reason for that is a pre-planned interim analysis by the Independent Investigator Data Monitoring Committee shows that this comparison actually reached the threshold of statistical significance that was preset on the pre-planned statistical analysis. That actually did not happen with the durva plus treme, so this comparison should be done at the end of the final analysis. Patients were treated in the 2 arms, with most of the cases, 3/4 of the cases with carboplatin, etoposide, in 1/4 platinum etoposide. Patient characteristics were balanced. At the time of the treatment, still 16% of the patients were on treatment with durvalumab, and importantly, 85% of the patients received 4 courses of therapy in both arms. But, as you remember, in the control arm, patients were allowed to have up to 6 courses of chemotherapy, and in fact, some 58% of the patients received 6 courses of EP. The number of doses of durvalumab was 7 on the experimental arm. Here is the main result, the primary endpoint of the Caspian trial that was actually met. Survival was prolonged for those patients treated with durva plus EP as compared to EP alone, with a hazard ratio of 0.73. That means a decrease on 27% of the risk of death all along the study period. That translates into an improvement in median survival from 10.3 months with the EP alone treatment as compared to 13 months with the EP plus durva treatment. Survival at 1.5 years, 18 months was 25% in the control arm as compared to 34% in the experimental arm. Consistently, response rate and PFS was also somehow prolonged for patients treated on the durvalumab plus EP arm. In terms of safety, we didn't identify any new safety signal here. For most of the cases, tox profile were similar among the two study arms. Same number of grade 3/4 events, same number of serious adverse events in the two treatment arms. Actually, discontinuation due to adverse events were similar, 9% in the two treatment arms. The main difference was in the incidence of immune-related adverse events, as actually was anticipated. Those patients with Durva plus EP had, in some 20% of the cases, immune adverse events, as compared to 3% in the case of EP. I have to clarify here that out of this 20%, some 5% of the cases were more severe, and actually 15% out of the 20% were actually thyroid dysfunction. So let me conclude. We believe that the Caspian trial met the primary endpoint. Survival was prolonged for those patients treated with the experimental treatment of Durva plus EP, as compared to those treated on a robust control arm with up to 6 courses of chemotherapy of EP, as we typically do in the clinical practice, and the use of PCI when indicated by the physician. Hazard ratio being 0.73, increase in median survival of nearly 3 months, 10.3 to 13 months. Importantly, survival at 18 months was improved, 25% to 34%. And very important, the benefit was seen similarly, the same magnitude of the benefit across all the study subset, including those with brain metastasis. Other secondary efficacy endpoints, response, PFS, were also in the favor of the experimental Durva arm, and no safety signal were identified. So we believe, based on those data, that Durva plus EP is actually a new and relevant, important treatment option for those patients with extensive disease, small cell lung cancer. Thank you.
Now, the press conference is open for questions from the press. Please. It's coming.
Thank you. Pam Harrison, Medscape. Either Dr. Lamb or Dr. Sullivan or Dr. Pastorino or all three of you, it sounds like the United States Task Force criteria for lung cancer screening should be thrown out because it really isn't a very good predictive. It doesn't have good predictive value for picking up early lung cancer. Could you address where your bio is the biofilm or the RNA, and then your assay, and then your risk prediction model? How do they? I mean, they're clearly screening is much more effective when you add something or change the criteria. Could you address that, please?
So it is now known that using the U.S. Task Force criteria based on age and smoking history, a decreasing number of people would be eligible for screening because there are more people stop smoking, and the people who are still smoking smoke less than before. So that's why we need to have a better prediction model to identify people who would benefit most from lung cancer screening. So that's where the PLCO risk prediction model would play an important role. And I see that also interaction with other biomarkers. So for example, the ones that were not suitable for using the PLCO criteria, but positive by a biomarker test, may make them eligible to benefit from screening, but we need to do the study to show that.
I completely agree with that. It is at this stage where the guidelines are in evolution. There'll be a work in progress as more scientific evidence comes forward. I think what biomarkers really add, along with using the patient's phenotypic characteristics, is the ability to increase the number of people who get into screening. At the moment, the SPTF guidelines are only getting 5% or less than 5% of the potentially eligible people to get to imaging. So if we could get more people in by using their phenotype, using the various biomarkers and working out what's the best combination, then we can start getting people over to the other side of the table, getting the newer effective treatments.
One of the major barrier to promote screening that even if we know that it works, is the skepticism of physicians and the skepticism of smokers. And one of the sources of skepticism is that lifelong smoker, 50, 60, they think that, you know, the game is already done. I mean, I either will have a cancer or not, but the risk is small, the benefit is small, and I know many people that have smoked all their whole life, and they didn't get any problem. So addressing this big point of defining among whole smoker who is gonna have a cancer, and designing the screening based on the individual risk, I am sure will improve the overall performance, compliance, development. So it's not just reducing the cost, but we have to extend the screening for 20 years. Is no point screening 2 years, 3 years, 4 years. I mean, you have to screen for the entire life, let's say from 55, 60 to 80, okay? And to do that, you have to select, or at least it's much better to select, because you reduce the cost, you reduce the harm, the useless pain that you cause by following individual with low risk in an intensive way, and on the other way, you are not intense enough for those who have a very high risk. So this is the beginning of the story. It's the beginning of risk modeling can not only improve performance, but also improve acceptance and compliance to screen and willingness to screen.
Other questions for other speakers?
Hi, Shriyananda from Medway News. Quick follow-up questions for Drs. Lam, Sullivan, and Pastorino. Are you worried about the concerns, like potential concerns of overscreening?
No, because we only screen people very high risk. So the proportion of so-called overdiagnosis lung cancer actually very small on long-term follow-up. So there's always a concern, but I think it's a very small problem.
What is reassuring is that after 20 years of screening, we can say the chest CT is much more reliable and effective in avoiding overdiagnosis if it is used at best. It's better than breast mammography. This is, in my view, demonstrated, both in terms of mortality reduction and in terms of unnecessary treatments. Of course, it has to be used properly. And then now with the ultra-low dose scans, you can do 20 years of screening with the dose of 1 or 2 CT. So it is becoming less and less harmful and more effective.
Just a quick question for Dr. Pazares. With the PFS data, obviously I can see that the risk is reduced, but the median PFS is actually lower for the Durva arm than for the EP arm. Could you comment on that, please?
Actually, the data show that the PFS overall is better for the Durva arm. Hazard ratio being 0.78. That means a decrease in the risk of progression all along the study period of 22%. You actually look exactly at the median times, there is no difference at all. The reason for that, I think, as compared to other trials, may be related to the fact that patients in the control arm in this very study were allowed to have 6 courses of therapy. Indeed, if you look at the curve, the separation actually starts after month 6, when patients had finished the 6th course of therapy in the chemo arm. But altogether, I would say there is an increase, of course, which typically late on the PFS arm.
There was probably another question here. The microphone, please. No, there is a question from the lady before.
Sorry, I don't mean to hog every, but I wanted to ask Dr. Lim, the discussion said that VAT has been around for decades, and yet it's very underused, at least from her presentation. Could you comment on why VAT is so, people are avoiding it, when it obviously, even cosmetically, the procedure is so much more pleasing?
That's a great question. And the very simple reason is that for VATs to be used, the surgeon needs to retrain. So myself and my generation of surgeons have grown up in the Nintendo generation. So we play lots of video games when we were young. And when we do VAT surgery, it's like holding a console. You're operating on a big screen TV. It's like playing video games at home. In fact, my mom said I'd never amount to anything playing so much video games when I was young. But as you mature in your, in age, and if you've been doing an open operation all the way, there's very little incentive to change. And so that's why Violet's so important. It's one of the first randomized trials, which is high quality, that actually demonstrates a whole range of benefits with keyhole surgery. Now, the uptake of keyhole surgery is very different in very different countries. It's very high at the moment in the UK, around 60%, but I believe that it's very low in the USA, and the often stated argument is that there is no high quality randomized data. Well, as of this morning, that argument won't hold anymore.
Any?
Could you just clarify, you said that the use of VAT is very low in the US, it's coming money in August, so it's only about 5%?
I don't have the actual figures, updated figures. 30%, that's half of, yep, and that'll be half of what's happening in the UK.
We should move on. Dr. Herbst?
I just want to make a comment, and I have a question for Dr. Drill. And it's incredible in the 20 years of this meeting how we've seen target therapy evolve to such specific drugs and the results you showed today. From a society point of view, I'm wondering how we're going to find these patients. So how are we testing? So in the United States and throughout the world, are we picking up RET in the tests that we're doing when we diagnose patients with lung cancer? Because we'll only be able to use these drugs if we find the mutations.
Yeah, I do think that there's an element of underdiagnosis, and unfortunately the testing question also comes with an economic question. I think if you're asking about the best possible test, we've shown that if you use comprehensive next-generation sequencing that has both DNA and RNA, you're most likely to maximize picking up RET fusions. Not only that, but picking up also other clinically actionable alterations that you have drugs for. However, in other environments where there's not access to such a test, other assays such as FISH or RT-PCR could be used, except the argument is that those aren't really optimal at detecting every single RET fusion. So hopefully as technology becomes cheaper and the turnaround time becomes faster as we move into the future, that we'll see more of this diagnostic migration around the world. But I think the best test to use is to do NGS if possible.
If there is no additional question for any one of the speakers, I believe that the speaker will remain available to every one of you during today and tomorrow if there is any additional question related to the studies. Otherwise, I would like to thank the speakers, all of you, for attending this press conference following the presidential symposium.